conversation now. We can talk about the ECVM requirement for becoming a cardiologist, whatever you prefer first.
Okay. I will right now. Hello, people from Brazil. Thank you very much to our interview with Dr. Michele Borgarelli. He's a friend of mine, and he's doing a great job in veterinary cardiology in the last 20 years. He accepted our invitation to be here today to talk about the delays, the study that started in 2010 and ended in 2016, 17, I believe. Michele, thank you very much to be here. I don't say to Dr. Charlys Rhands, thank you very much to allow us to use his Zoom platform to show to Brazilian people the result of the study. Thanks, Michele.
It's a pleasure for me.
Thank you, Guilherme, for inviting me. I always enjoy speak with people from Brazil. I hope I will be able to come back there one day next year. So there will be a more direct conversation about the delay. But thank you very much for inviting me to this.
You are. If you want, we can do you want to share your slides right now or just talk about it?
Yes, we can start. Okay, share. Well, desktop. So you can see this. Can you see the slides?
Yes.
Yes. Yes.
Okay. So do you want me going through the major results of the study, the delay study?
Yes, just I would like to know how many centers were in the delay, and how was the history about the delay study?
Yeah, so the delay study started 9 years ago, actually almost 10 years ago. And it is an idea that came out from a discussion with a group of Italian cardiologists that eventually formed a scientific committee for the study. And this group of cardiologists was including Dr. Bussadori, Dr. Chiavegato, Dr. Daniel, Dr. Migliorini, Dr. Poggi, Dr. Santilli, Dr. Ferrazin, and myself. So the study was originally designed as a study, okay, why we don't try to test what the drug like spironolactone and benazepril can do. And the idea was coming from the fact that we know that in dogs there is alternative pathways for activation of the renin-angiotensin-aldosterone system, and then there is aldosterone escape or aldosterone breakthrough mechanisms very well known. So we put a concept paper about a study, and then we contacted SEBA, and there was an interest from them, and so the study that was starting as a small study became a bigger study. And the bigger study, I can show you a couple of slides here. So originally, can you see this slide?
Yes.
Yes, okay.
So originally there were 16 centers. It was just an Italian study, so there were 16 centers in Italy. And then we had over the time 1 center in Netherlands and 4 centers in UK. And so at the end, we had 21 centers all over Europe that were enrolled in dogs. The study took longer than was planned, and it took 9 years before we can get to the results. But now it's done, and we are happy.
Great. And how many dogs would you recruit at your study?
So we planned to, let me go to this. So the study design was based on the power analysis. And so we based our power analysis on data that were available in 2008 when we designed the study. And these were data that were coming from our study on natural history of mitral valve disease. Based on this study, we knew that a dog has 60% chances of not progressing to heart failure in 3.5 years. Based on this, we did a power analysis, and it was planned to enroll at least 200 dogs for being able to identify a difference of 22%. Because this was already planned to be a long-term study, and you know the owners can lose interest in staying in the study, or there were other factors that cannot control, we hypothesized that was a possible withdrawal from the study of 20%. So we planned to enroll 240 dogs. And here it's actually what the number of dogs we want to plan. Also, one of the risks in doing multi-center clinical trials is that you have some centers that are very effective, so they enroll a lot of dogs, and other centers that enroll very few dogs. And that can create a bias by center in assessment of results. So in the study design, each center could enroll a maximum number of 14 dogs to avoid this bias. Bottom line, we enroll at the end 183 dogs in this study. So 184, but in reality, the population of dogs that was formed was 183.
Great. And how many dogs was in EPIC study?
In the EPIC study, there were 360 dogs that were enrolled. So we enrolled about half of the dogs that were enrolled in the EPIC trials.
And why the US centers did not decide this study?
Oh, because this was originally designed as a European study. So we did not have, from the beginning, and planned to do any study here in the United States at that time.
And how the EPIC study exchanged the delay study recruitment of dogs?
I think I understand your point is that EPIC and delay study were running more or less at the same time. So there was a little bit, the EPIC trial started a couple of months earlier than the delay study, but essentially they ran at the same time or together. So, but the EPIC results were presented earlier. As you know, they were presented in 2016. So that was an ethical issue that time because we had a placebo-controlled trials. So knowing the result of the EPIC trials, we wanted to be sure that we were not doing any harm to our patients. So at that time, what we did was an unplanned interim analysis of the data. So interim analysis, essentially what you do is just you analyze the data that you have in a blinded version. So you still don't know what group A and B are, but you analyze if group A and B are different, they behave differently. And at that time, the study was showing no negative effect of one group over the other one. So we continue to do the study. Also, after the EPIC trial results were public, we offered to every owners that enrolled their dog in the study the opportunity to leave the study and get Impimobendan. And we get only, I think, if I will remember, one or two owners that decided to leave the study and start Impimobendan at that time. So what happened is that the EPIC trial did not change or did not influence the delay study as enrollment because essentially we already enrolled almost every dog at that time the EPIC trial came out. So all those that were, the enrollment phase will close when the EPIC trial results were out, and only 2 dogs left the study at that time.
And what are the biggest issues that you have to enroll dogs in a multi-center study?
Sorry, can you repeat that question?
What are the biggest issues to enroll dogs in a big study like a multi-center study?
A study like this one is requiring a lot of efforts If I knew from the beginning, probably, I don't know if I were taking the task. As a principal investigator of the study, you had to coordinate all the investigators' work and maintaining independence of the investigators from the company. And so that is an important thing. You want to be sure that essentially your result, your work is independently from what the company wants to do. And that was a great experience because I have to say that Seba was really great and try not to interfere more in our work. Enrollment has been one of the most important issue we had in the delay study. There is people perceive the word study, clinical trial, as a bad word. So they are scared or afraid that if they enroll the dog in a study, it's a sort of experiment. And so it's the investigators had to find the correct strategy to explain that the clinical trial is not something, is an experiment where you try to figure out something strange, but is the optimal way to test a new treatment or to test if a treatment is working or not. So we had a period where we were not able to enroll dogs, and other periods where enrollment was faster. But we also have the owners that they decide to get in the study and then leave the study in the middle of that because they get bored or they change their perception of the study.
Charles, do you have any questions?
Yes, I'm have a question about how was working with a conflict interest with a sponsorship. It's a trouble for this study because the several companies participate in the do the sponsorship about this study. How was working with this conflict interest?
Well,
Sorry.
today, every clinical trial has very precise and strict rules about the conflict of interest. So from the beginning, the contract that we all signed between the investigators and the sponsor was that we own data. And so we had the right to publish result of this study, whatever the result had been. So that's the key point when you have a study that is sponsored by a company. The investigator should have the right to publish, and they own the data. So the data are owned by us and not by the company. The other important aspect is you need to have independent statistician. So you don't have statistician that is an employee of the company or a statistician that is friend of you. You should have somebody essentially is independent, doesn't know results, is not much involved in the study other than doing the statistical analysis. The other aspect is all the statistics and all the result analysis has to be done while it's blinded. So results, I didn't know the result of the study, which group was A and which group was B, up to the point that we decided that, okay, we are done with every statistics possible. There's not much we can know. Now we need to know what group A and B were. But at that time, the database was frozen, so you cannot change the data anymore. That's everything is frozen from that point on. So what is done is done. And yeah, you can do small adjustment if you just notice there is a mistake, sometimes happen in the data, but that's been not.
Okay.
And what are the results for the secondary and Charles?
No, so only thing, GOLDFEDER, for us with work with research, it's clear, but it's important for our audience here in Brazil. So and then sometimes believe that this researchers work with conflict of interest. It's have some influence of the sponsor. It's important to. It's the reason I'm asking to you, teacher, about this question.
Yes, it's
Okay,
good.
so as I said, we have all the investigators receive some sort of funding from the company for traveling, for having investigator meetings or whatever. But this did not have any influence on the data because this is a blind study. So, and the data were, as I mean, we are not done. We are not seen the result yet, but as soon as you see the result, you will understand that essentially this is a very independent study because the results are interesting, but
Amazing.
can be a little bit, I'm not saying disappointing, but failing to show some result that we are expecting.
And what are the results for the primary and
Okay,
secondary?
so I think that the three important, the most important slides is understanding results of this population. So I can go, you can still see this.
It's very small.
I can go, it is better now?
Yes, so
yes.
much better.
Okay, so 184 dogs were enrolled in the study. And from this dog, one dog was not randomized. So the owner changed his mind the day after, so never get a randomization number. So you have 183 dogs. Of these 183 dogs, 2 dogs were already in a heart failure when we look back and we confirm we look at the data of the study. So these were not, so sorry, before moving forward, on this side here on the left, this is the treatment population. This on the right, you have the placebo population, okay? So 2 dogs were excluded in the treatment randomization group because they were heart failure, and 2 dogs were excluded from the placebo arm of the study, one because never received the treatment and the other one because he was in heart failure. So you end up with the 183 dogs, and so 178 dogs. 87 dogs were in the treatment population and 92 dogs in the placebo population. From these, 5 dogs in the treatment group and 6 dogs in the placebo group were eliminated by the per protocol population, mainly because lack of owner's compliance. So lack of owner compliance is an important aspect in any long-term trials. So owner compliance is going from fact that they don't show up for rechecks or they don't give the drugs systematically. And there is a similar mechanism through which you check if the owner is getting the drugs, giving the drugs or not. For example, you count the pills. When they come back to rechecks, they always to bring back the bottle with the pills, and you can count how many pills have been given. So you understand easily if they have been given the drugs or not. So if we go to the per protocol population, we had 82 dogs in the treatment group, 86 dogs in the placebo group, and 42 dogs reached the primary endpoint, that it was heart failure or death for cardiac disease in the treatment group, and 33 dogs reached the primary endpoint in the placebo group. So we have 40 dogs that were censored in the treatment group and 553 dogs were censored in the placebo group. In the treatment group, the most common cause for being censored is that these are dogs that reach the end of the study and never develop heart failure or they die for the heart disease. And that was the most common reason for not reaching the endpoint in both groups. And then non-cardiac death is the second most common reason. There were no difference between the placebo group and the treatment group for all the dose characteristics, the dose of test medication, quality of life and respiration variables, physical exam variable, diagnostic imaging variables, so echocardiographic and radiographic parameters, and the laboratory variables. So these 2 groups were very similar from the beginning when they were being enrolled in the study. And there were no different for breeds too, and the most common breed that was enrolled in the delay study were mixed breed dogs. These are quite different from other studies like the EPIC, for example. where the most common breed was Cavalier King Charles. And in our study, only 19% of dogs were Cavaliers. These are the inclusion criteria parameters. So dogs for being included in the study had to have a left atrium aortic root ratio more than 1.6 or endostoid diameter normalized according to the Cornell formula more than 1.7. There were no difference between the two groups about when they were enrolled. So they have very similar results. Dose of benazepril and spironolactone, this was the medium dose of benazepril. This is the mean dose of spironolactone. This is what is recommended normally by the companies, so not a big surprise there. So median survival time, so this is the time for the dogs enrolled in the study to the point they reach the primary endpoint. It was 1,045 days. That's pretty much what is being reported by in other studies, so not a big surprise here. The intention to treat population, they have much shorter heart life, so we are 925 days. And we will see this a little bit later why. So the primary endpoint results, there were no difference between placebo group and, so the placebo group is the red line and treatment group was the blue line. So there is no difference in time to reach the primary endpoint between the two groups with a P of 0.456. This is for the protocol population. In the per protocol population, so these are the dots that were strictly following the design of the study. We have 51% of dogs that reach the primary endpoint in the treatment group, and 38.54% of dogs that reach the primary endpoint in the placebo group. Cardiac death, this is another important aspect. So maybe there is no reaching any point, but there was an effect on cardiac death. There is no difference in the number of cardiac deaths between the two groups too. And these are the variables that were associated with the outcome in this population of dogs. And some of them are the usual suspect as you expect. So like LAO, hip peak velocity, endostoid diameter, and the VHS on radiographs, and an 5-beat increase of heart rate. So for every increase of 5 beat in the heart rate, you have a significant increase in hazard ratio. And this is also the first study. It is an important thing of the delay study. It's the first study that looked prospectively to the values of NT-proBNP to identify prognosis. And the NT-proBNP, so for every increase of 100 picomoles per liter or NT-proBNP, you have an increase in the risk of reaching the primary endpoint. All these variables were not associated with a treatment effect. When we look at that in the multivariate analysis, the only two variables that remain significant were that increase of 5 beats per minute of heart rate and the endostoid diameter normalized. So every 0.1 increase in the endostoid diameter is increasing the risk by 14%, essentially. That is a significant one. So if we look at the intention to treat population, you see that actually, again, there is no difference between the two groups. If you remember, we noticed that when we have intention to treat population for all dogs, the survival time went from more than 1,000 a day to 925 days. And here you see the number here. Now, you have to remember that the difference between the intention to treat population and per protocol population is only 6 dogs. So in a study like this one, 6 dogs in one arm is decreasing the survival time by 200 days. That is almost 7 months. That is important because it's just telling you that in a small study like delay study, a small number of dogs made a huge difference between regarding the possible result that you have. So we have 6 dogs more in the placebo group here. The red line shortened the survival time by 200 days. And no difference in the number of events between the two groups. Mortality, again, there is no difference in the mortality in the intention to treat population. So the other thing that is important, and now we'll go through in the interesting result, is that the delay study had a pre-planned, and then it's a very important aspect. This was pre-planned, it's not a secondary analysis. The pre-planned analysis was also, can we see any effect on clinical parameters, radiographic parameters, echocardiographic parameters of NT-proBNP? So this was pre-planned before starting the study. And here we see results of the study. So in red, again, you have the placebo, and in blue, you have the treatment group. So you see that essentially in the treatment group, heart rate remains quite stable, where in the placebo group, the heart rate is going progressively higher. The VHS is also increasing more is in the placebo group, and where actually you stay stable in the treatment group. LAO and peak velocity at the same. So the left aortic root ratio has a trend to increase in the placebo group, but actually is decreasing over the time in the treatment group. Now, this difference becomes evident from visit 3 or visit 4 on. And that is an important aspect, because to me, it's just showing that there is this treatment is a chronic treatment that requires time to see some differences. So we have differences, they're always showing up after visit 3 or visit 4. And diastolic diameter, so the gray or modeling, we have the same things. We have a progressive increase in diastolic diameter for patients that were on placebo, where we have a reverse remodeling in the patient that were on treatment, where there is an increase in the diastolic diameter for both the groups over the time. NT-proBNP, same things. From visit 6 to visit 8, remember we did visit every 6 months. So for every visit 6 and visit 7 on, there is a significant difference between the NT-proBNP, between the treatment group and the placebo group, where the troponin I is also different. But I mean, it looks different, but there are no significant differences between the troponin I. And it's not an unexpected one. We don't expect to see many changes in the troponin in these patients. We have evidence that the treatment pharmacologically working is when you look at the urine aldosterone concentration. So if you look at the urine aldosterone concentration, there is an increase, significant increase in the urine aldosterone from visit 3 on compared to the placebo. Remember that spironolactone is blocking the receptor for aldosterone in the tubules. So you expect that there is an increase in the aldosterone in the urine because you block the receptor. So these are results very similar to what's been reported previously by other groups. And then is an increase of almost 200% from the baseline to the patient that had visit 8. So to us, this is showing there is some pharmacological action of the drug. The aldosterone in the urine is also going up in the placebo group, and we believe this is probably because these dogs are remaining in the study, so over the time they progress. So probably there is some activation of the renin-angiotensin-aldosterone system, so you see an increase in the aldosterone in the urine, also in the treatment, in the placebo group. And this also probably explains why the urine aldosterone creatinine ratio is not different between the two groups. It's probably reflecting both in the placebo group, there is a more an activation of blocking the aldosterone receptors, where in the placebo group essentially is activation of the RAS. There were no differences in the adverse events, so both groups have the same number of adverse events, and there were no serious adverse events. So you can see the treatment is safe, because this essentially what this table is telling you is that this treatment is safe. There is no difference in the things. And so this is essentially the summary of the delay study. The delay study has neutral results or has failed to show a positive effect on delay onset of heart failure in this population of dogs. But all the secondary endpoint of cardiac remodeling and neurohormone activation are positively affected by the treatment. So, and this is the first time we have a study where there is all the secondary endpoints in one direction, and the primary endpoint are not positive.
Okay, great. Amazing results. We're expecting the negative results for the primary endpoint. And do you have any idea why the association between benazepril and spironolactone?
We think there are two major factors in this aspect. The first one is we enroll relatively mild dogs. So remember that, and I can go through these. Let me check if I can find the correct slides. So let's start with this one. The study could be underpowered. Okay, so if you remember, we wanted to enroll 240 dogs, and instead we enrolled 184 dogs. However, to be very honest, we wanted to enroll 200 dogs. Okay, that was our target. We decided to go for 240 dogs simply because we thought, well, there would be 20% of dogs that will drop out from the study. Our target was to enroll at a minimum 200 dogs. Now, so we are talking about 16 dogs less of what was our original target. The other problem is that we have a relatively mild population of dogs being enrolled. So 35% of the dogs being enrolled in the delay study had a left atrium aortic root ratio less than 1.8, and about 27% of dogs with had end diastolic diameter less than 1.8. So that essentially means that a third of dogs were affected by the disease. They have some degree of remodeling, but the degree of remodeling was not that severe. So you probably have a mild population and a little bit too small number of dogs that have been enrolled. So when you have something like this, you have a low risk for event, a low number of events, because the mild population suggests that this population is a lower risk to experience an event. And also, if you have a small number, then it's difficult to find a difference. So essentially, when you have a mild form of disease and low number of events, you need much higher number of dogs to be enrolled. Indeed, we had a post hoc analysis where we used the data from the delay study. So we used the actual data from the delay study. And with the actual population and the rate of events in the population, we had to enroll 3,000 dogs to find the difference between the two treatments. So just telling you that actually, that obviously is not feasible in veterinary medicine, but this is the number that we had to probably with the current thing. The other thing is that if you have a low risk for an event, you have to follow up these dogs for a much longer time in order for being able to identify an effect. Because if you have a very mild dog, this dog will stay in the study without experiencing an event for much longer time. So, but you obviously, when you have a dog and you have a sponsor, you cannot go for, okay, we're going for following up this study with this dog for 10 years. Nobody will never sponsor a study that lasts 10 years. Well, we were close because we are 9 years, but that was including enrollment and was also including the follow-up. It's not only including the enrollment phase. So that's another aspect. So to us, these are the two major aspects that probably has led to the fact that we were not able to identify any effect on the primary event.
Great. Charlys, do you have any questions?
No. This time it's all okay. For here in Brazil, we use the benazepril twice in a day, and some guys utilize them twice for a day. And this use only in 24 hours. It's a problem to the study, or but it's put in this study because the sponsor, or it's the thing of the researchers.
I think clinically everybody is using benazepril twice a day.
Yes.
One thing the delay study is showing today, we don't know because we cannot assess the renin-angiotensin-aldosterone system activation because we just look at aldosterone in the urine. Okay, so we didn't have any values of the angiotensin 2 in the blood or anything, so we did not plan for that.
Okay.
But based on the result of these slides here, let me go back here. I think that we give spironolactone once again, once a day. You have a pharmacological evidence of action of the drug. So at least for aldosterone, at least for spironolactone, I think there is evidence that you can give the drug once a day, because remember, this is urine aldosterone is a surrogate of measuring aldosterone in the 24 hours in the urine. Okay, so, and then the fact also the urine aldosterone creatinine ratio is going up here in this graphic, and it is going from 0.6 to 1.7. So is more than twice or was originally here. So this is, to me, suggesting that there is a pharmacological action of the drug given once a day.
Amazing. Thanks a lot.
And if, actually, now you showed us the results, the good results to spironolactone, but do you believe that veterinary medicine, we did not find the correct way to block all the systems? Because of that, we do not have the results as the humans?
I'm sorry, I can't hear very badly. What was the question? Can you repeat the question again?
Yes, of course. You showed us the good results about spironolactone to block the aldosterone, the animals, the dog's body. Do you believe that in veterinary medicine, we did not find the correct way to block all the systems? Because of that, we did not have the same results?
Well, I don't know the answer. I think there is, based on the work from Dr. Clark Atkins and Marisa Ames, there is some evidence that essentially you have a aldosterone breakthrough mechanism. From experimental models, work done by the group of Dell'Italia, also we know that the kinase pathway in dogs is pretty active. So there is a way that despite you give an ACE inhibitor to this patient, they can still activate the angiotensin 2 and aldosterone. So this is coming from experimental models and both from clinical dogs, as shown by Dr. Atkins and Dr. Ames. I think if you look at this graphic here, the fact that the aldosterone is going up, even the placebo group is going from almost 0.6 to 1.5. So it's increasing by more than 2.5 times. This is showing that, and remember that each visit essentially means these dogs are longer in the study. So a dog that when we look at the V8, essentially this dog has been diagnosed with mitral valve disease for 3.5 years, okay? And then it's still preclinical. But essentially, I think this is showing there is some activation of the RAS over the time, even in the placebo groups. So we have, maybe not at the beginning, but after a while, the closer you get to the point that you get to heart failure, the more activation of the RAS is there. And so I think that we need to go for a more effective block of the RAS, probably yes. And because the aldosterone breakthrough, I think probably it's veterinary medicine, we should use a combination of both spironolactone and an ACE inhibitor. And maybe the future of an angiotensin 2 blocker too. You know, that's the other aspect that nobody never talk about, but maybe that would be a better way to block the RAS in our patients, given an angiotensin 2 blocker too, that we don't know much about.
Great. And what are the future directions to use ACE inhibitors? Do you believe we should prescribe only stage C or D, or maybe in the future we can think to use in B2 dogs?
I think that we should not underestimate the result of the delay study for the secondary endpoints. We need to be careful, okay? I want to make this clear. We need to be careful how to interpret this result. We don't want to overestimate the results, but we cannot just forget about them. So result of the delay study on the secondary endpoint, they show that with the progression of the disease, all parameters of echocardiographic parameters that are independently associated in any study, you go to the EPIC, you go to the Howard study, you go to the study from the Royal Vet College, they look at the echocardiographic parameter remodeling, so left atrium aortic ratio or end-diastolic diameter. In each of these studies, essentially, these are parameters that are associated with the worst prognosis. So to me, it's not really smart to ignore these results. Okay, so say, okay, if the treatment is effective on reverse cardiac remodeling or slowing down the progression of the disease, as demonstrated by NT-proBNP, NT-proBNP remains flat almost in the treatment group, where going up in the placebo group. So that's probably is important thing. Do I prescribe now spironolactone and benazepril to every dog that is B2 dogs or whatever is the new classification for ACVM? Well, probably not. I will probably wait that the population, this dog is more severely affected. So we're talking about LLAO more than 1.8 and end-diastolic diameter more than 1.8. These are data that we cannot still show, but we are data that's probably, if we go for that population of dogs, probably we will be able to find an effect. So yes, the study changed my perspective. I was always being a ACE inhibitor skeptical, honestly, but I think based on result of delay, now we started to prescribe spironolactone in dogs that are preclinical, so in heart failure, but they have significant remodeling in their heart.
Any comments?
I don't really. It's a problem with your microphone or internet. You can repeat. You without sound. But
now he asked if you have any other question.
Okay. No, Tisha, I have a question, but a different question. Question about the future. Another ways to the therapy, like the neprilysin inhibitors. Do you have some comments about this way of the new research?
Sorry, which research?
About the inhibitors of neprilysin inhibitors, like valsartan plus sacubitril.
I don't think that, I don't know anything about that so far. I think there are probably some study looking at that, but we need to wait result of this study. One thing that I learned from the delay study is that you just have to wait.
Okay.
And as I say, remember that when we do studies in medicine, we still do in a small number of dogs. And as I show you in the difference between intention to treat and per protocol population, 6 dogs make 200 days difference in survival time. Remember that we have 6 dogs more in the placebo arm, and we have 6 dogs more in the treatment group. But the feature of the treatment of these 6 dogs between the placebo and the treatment group makes the 2 curves much closer each other. So the risk is that what happens if you have 20 dogs more in each arm? Maybe the result could be different. I'm not saying that they're different in favor of the treatment. It could be different in favor of the placebo. We don't know. We can just speculate on that. But we need to be careful when we look at these numbers in small groups. So making any conclusion before you have the full result, it's almost dangerous.
Okay, amazing.
Can you hear me now?
Yes.
Yes.
And when are you going to start the delay 2 study?
Where I'm going to start the delay to, I don't know. I want to show these pictures that I didn't want to show, but as you're recording now, I think I want to show you this. So you've already seen this picture, but this is me when I start the study. Okay, this was me. This is me when I end the study. So you see the difference, you know? 9 years make a huge difference. If I do this delay 2 study, I risk to be like this. And I don't, so I don't know if I have the strength to do this by that time. I think that we probably do more investigation. There is another, you know, that, Guilherme, that we are running the large database so far on mitral valve disease. So we have the Look Mitral study. We enrolled 6,100 dogs. So this is essentially a study where we can start from. So we get data about treatment in a large population of dogs. Even if it's not randomized, double blind, you can just check a very easy endpoint like that for the patient. So you can start to look at that number and see if there is any real difference when you look at treatment, for example, with spironolactone versus dogs that were not receiving spironolactone. So that is making this kind of study shorter, easier to run, and less expensive. So that can be a possibility. It's also possible that we will repeat that, try to do the delay study too, with a more advanced population of dogs. But that is something that we don't know at this time.
Okay. It's amazing results. I do not have more questions. Do you have questions, Charles?
No, it's okay.
Okay. Yeah, you can conclude the slides.
Can I turn off the slides?
No, you wanna show this summary? No, actually, I was talking.
I'm back here.
Okay, Michele, thank you so much. I believe the results are very interesting. People in Brazil, they're anxious to know when you know about new guidelines, about new studies. People, they always want to know the results and exchange the way that they do their treatments.